Okay, thank you, everybody. We will start on time. We've got a few more people who will obviously be coming um, in to join us, but as you would note, we are recording it. I think some of you may have come in before the record button actually got pressed. But hi for everybody. On behalf of Tracy, I would like to welcome you all to the webinar today, and really pleased to have you online for this topic that I think is a really crucial topic for the children that we work with. Before we start though, I would like to acknowledge the traditional custodians of this land and the lands on which you're joining us from today. I'm on Whadjuk Noongar Boodja in Western Australia, and I pay my respect to elders past and present, and to any Aboriginal and Torres Strait Islander peoples here today. So today's webinar, actually, I'm going to start as people are still coming in, just to talk briefly about the Precy road trip. The QR code that you can see there is actually for the Precy Humanitics page, which will take you to all of the upcoming places that we're visiting. You can see there I've got Darwin and Alice Springs because that's coming up next week. But after that, we're in Adelaide, Canberra and Melbourne, so and then Perth in November. So if you go to that page, you will be able to link in, and there are 3 areas that we're covering. The first one is looking at tools and resources that support the implementation of the framework. The second is around professional standards for early childhood intervention, because currently Australia doesn't have any. And the second day is actually on coaching, so it's training on coaching. So I'll leave that up just as I do the introduction. Actually, I might, Mihiri and Joe, I might get you to share yours. So I'll stop sharing mine if you want to share yours. And as I introduce you. So today's webinar touches on a subject that I am sure all of us who are working in this area with children with developmental concerns, delay or disability have experience with. Whether that is supporting a child and their family with toothbrushing itself, and whether there's challenges with that due to physical or sensory issues, whether it's answering questions of concern from families about how to choose a dentist, or challenges that they may have had with their child attending a dentist, or even when families have concerns about pain or teeth grinding. So I think it's just a really important topic for us to have a discussion around. And we do have a small group today, which is really lovely. So there's going to be lots of opportunity for discussion and interaction. Please use the chat, but you're also very welcome to come on video. And thanks to Paula for helping us with the chat and questions. So really pleased to introduce our 2 guest speakers and thank them again for presenting on this topic. So firstly, we've got Joe, if you want to do a wave, Joe. So Joe Thorpe is a senior community health leader at Access Health and Community, leading a team delivering early childhood intervention services across multiple sites. Her background is in physiotherapy, and she's dedicated to leading the sector through reform to drive meaningful early childhood development outcomes across diverse communities. So thanks for being here, Joe. And then we have Associate Professor Mihiri Silva, who's an academic at the Melbourne Dental School, University of Melbourne, as well as Murdoch Children's Research Institute. So Mihiri's research tackles childhood dental disease, including tooth decay and other conditions that weaken teeth. And she's interested in evidence-based, person-centred approaches to improve child oral health. So the topic today, as you can see there, is open access, rethinking the impact of dental care for every child. So thank you, Joe and Mihiri.
Thanks, Denise. Hello, everybody. It's a Privileged to be here and share, I guess, some of the work that we've done, some of the insights. And Denise, as you said, it's great to have a little bit of an audience. So we're very happy to have a interactive session. We've put together some ideas and thoughts that we thought would be helpful, but we're also very happy to explore specific areas because it is actually a fairly broad topic as well. Do want to begin by as well acknowledging the traditional custodians of the land, and particularly the Wurundjeri Woiwurrung and the Bunurong peoples, the Yorta Yorta Nation and the Dja Dja Wurrung peoples. I'm here in Parkville today at the University of Melbourne. I want to pay my respects to elders past, present and emerging, and I extend that respect to any Aboriginal and Indigenous people who might be joining this session. I'm going to let Jo start us off with a little bit of a case.
Yeah, great. Thanks, Mihiri, and thanks everyone for having us today. So we're going to jump straight into a case. I think we just wanted to set the scene with the context of what we're talking about. So Dane is a child that I imagine many of you are sort of seeing in some of your settings. He's 6 years old. Diagnostically, he has a diplegic cerebral palsy and GFMCS5. So this family has just an enormous amount going on. They live in inner East Melbourne and are supported by our team, which works in their catchment. The family come across with a lot of barriers that are part of the challenges of them intersecting with really any system across their health needs. But in this kind of scenario, we were really thinking about the barriers that they face around getting appropriate oral health support. So they are non-English speaking. Dad has some very limited English that can kind of get the family through day-to-day needs, but certainly need interpreter support for any kind of health navigation or complex conversations. Dad also works sort of 60 hours plus, so he's the main coordinator for the family, but is really hard to get in touch with, and is also the only family member that drives. So mum at home with 3 kids is really isolated in many ways and is going to have some significant challenges accessing anything outside of the home. Dean himself, like many children with disability, has a whole lot of intertwining needs in his broader health and development needs. So for a family like this, oral health was often really deprioritized. They sort of saw the pressing needs of other parts of their presentation. So yeah, next slide. The way we'll talk more about how this project was set up, but what actually happened in this scenario was that as part of this project, we were actually able to go to the home with a specialised paediatric dentist, key worker present, interpreter present, and with him in his natural environment, we were able to conduct a really thorough oral screen. Mihiri, if you want to talk to the findings in that screen.
Yeah, so our team went out to the home and as Jo said, facilitated by the wonderful support from the CFT, we're able to conduct a dental examination. We found that there was quite high levels of tooth decay and particularly the front teeth were quite badly affected, and so much so that the decay had destroyed the tops of the teeth, and when the nerves were exposed. So the summary was that that Dean would need quite extensive dental treatment, and that would need to most likely be done under an anaesthetic. And we were able to arrange a referral to a specialist sort of tertiary setting through the public system that were able to meet the family's needs.
So I guess we wanted to start off with this to kind of demonstrate that level of health inequity, particularly when disability and or developmental delay are part of a family's experience. It comes down to language, transport costs, sensory needs, and real system navigation challenges. So yeah, we'll talk more now about the actual
project. Yeah, and I guess I'm going to just start with a bit of an overview about oral health, and just give you a bit of a snapshot about, you know, how common are children like Dean, and it's actually quite staggering because I think for many kids in the community, they do have good oral health. And I have to say, first of all, one of the real issues is that we don't have a lot of good data about the oral health of kids before they reach schools. And most of the data then is collected at school. So that, sometimes kids with disability who, some of that data isn't quite coming through. But we know that it's still quite common. So even those school-based surveys, and the last one was a little while ago, it's a new one being conducted now, shows that about a third of preps have already had tooth decay. But what's, I think, more concerning is that there's a group in the community that have, and this is a plot that looks at the cumulative distribution of the disease, if you count number of tooth surfaces and the overall population. And what you can see is that it sort of goes up exponentially, and that last 20% of the population have, 80% of the disease if you were to count the number of decayed teeth. And this is something that's been found for a very long time, that there are groups in the community that have very high levels of disease. These are the kids that are having toothache that's stopping them from taking part in regular activities. It's disrupting their family lives. Their parents are having to, stay home from work. It's leading to infection that leads to hospitalization. Actually, dental causes are the highest cause of preventable acute hospitalization, and particularly in the age group from 5 to 9 years of age. And so, and most of it is surprisingly, I guess, preventable. But there are some challenges in terms of getting that prevention in. Now, when we say 20% of the community, there's differing needs. There's lots of different people in that 20%, but certainly, and acknowledging that some of the data is lacking for kids with disability, and so on. But we know that those kids who have even just sensory needs, autistic children, developmental concerns, or significant disability and other medical conditions can make it really difficult to access dental care. And I guess that's where there was a real opportunity for us to partner with Access and community health. So I think actually, before we get on to that, Jo, I did want to say we have started to get some insights from the recent Royal Commission and the National Roadmap, which did some consultations. And I've put a quote here that's featured in these reports. And it sort of speaks to there's a real tragedy with parents sort of really having to pick up the burden of navigating a very complicated health system. They sort of need that support. They come up against all sorts of barriers from people who might genuinely be trying to help them, but who probably are completely misguided or like outright incorrect, unfortunately, at times. And so it's a really challenging environment. But whilst we are lacking a lot of data, the story is certainly coming through, and certainly comes through, I guess, to those of us who work in community services, and specialised sort of care as well.
Yeah, so I guess this project kind of was born through my predecessor, but also because at Access Health and Community, the Child and Family Services co-locate with our community health dental program. And so we actually intersect a lot in the corridor and the lunchroom. And that's really helped, I think, just kind of build awareness across our team. But we really identified as a child and family team that we were still really struggling to know how to support our families when we could see that this connection to good oral health prevention and then support if needed was quite challenging. Again, even for health professionals, it felt like a really difficult system for us to navigate, let alone as key workers to support our families to navigate. So we called this out and connected to a grant and to the University of Melbourne team, and have been able to conduct this program and this research together. Oh, yeah, just to kind of highlight where we are in the world. I know many of you may already know, but Access Health and Community, largely inner and outer east of Melbourne. But importantly, we, as a community health provider, are really working with families who are low income or have vulnerabilities and are in that kind of priority cohort. So kind of important to know that that's the context of the families we're working.
So we actually we had a program. It all started with the original sort of 4D project, and it was really had multiple components. And then one of the first things we did was to sort of set up a parent advisory group. We had parents coming not just from the access area actually. So parents came from different parts of Victoria and different contexts to kind of help us come up with the project, and they continued their involvement and engagement throughout the project, and they still are. We also were aware that there was actually a lot of lived experience and expertise within the child and family team as well. So we sort of lent into that a little bit, and we worked very closely with some staff from the Access child and family team who brought their own lived experience as well, which I think really enriched it, and it made it a really engaged program. And there was a lot of I guess communication going sort of back and forth rather than we're developing a program for somebody else kind of thing. It was very much done together. The program involved some dental visits, and we've touched on that already. We actually offered 3 options for the dental visit. So we offered, first of all, there was one dental clinic within that Access catchment area, the public dental clinic. We offered visits there. We offered visits at the specific community health centres, and we also offered home visits. For those of you who work with families, I'm sure you won't be surprised when I tell you that actually no one wanted to go drive to the dental clinic. Everybody either chose to have a home visit or were happy to be seen at the local community clinic that they were used to and they attended regularly. One of the things that it was quite a process in setting this up, in sort of how information was shared, and it was a one-off screening session, as you can see from this visit, which was conducted at home. But we also were very mindful of the need to make sure that there was a clinical pathway for ongoing care. As part of this program, we also conducted interviews with parents. So as well as having a parent advisory group, we actually did qualitative interviews with the families. And we also did some focus groups with dental practitioners, which was around Victoria, but also in Sydney as well. We developed some resources, so this was our first attempt at it. Maybe not the best, but certainly we went to great trouble to get photos of the dental clinic that no one ended up going to. But we know that it is important, and it is sometimes a challenge, and that preparation is really important for families. So the simple resources we tried to develop, and again, it was sort of worked up with the parent group. Just a little bit it was just not a massive study. So I think we had about 27 children, and they all had some kind of developmental concern. Just want to point out the age group. So some of these kids were from the same family, so they were sort of siblings. It ranged from just 1.5 years old to 7.5. That was most of the kids were under 6, and the average age was 4.4, as you can see. And we had some with significant sort of medical comorbidities as well. Now I'm just going to sort of work through these ones, because I thought that obviously we've got lots of data, and I just sort of wanted to touch on this, and I will talk a little bit more about the child dental benefit schedule, but it's a federal government scheme that provides many families with about $1,000 worth of free dental treatment. They can access that through their local dentist, private as well as public. And you could see from this that surprisingly, despite the fact that these kids, they're already coming from a society, families that were facing quite a number of barriers, as well as having a child with some developmental concerns. Not everybody was eligible for it, and a whole bunch of them, despite our best efforts, we couldn't find out if they were eligible. But there is, about a third or 30% that were eligible for this scheme as well. The scheme is very well known for being underutilized. So most of the families that we spoke to did not know about it and were not using it. And so that was a useful exercise for some of them. And you can see that we had some families had already been to seek dental care, but many had not. Toothbrushing was about 40% of the kids were having their teeth brushed twice a day, but there's clearly some challenges there. Just wanted, toothpaste. We're starting to see lots of kids using non-fluoridated toothpaste, which unfortunately is not as effective, and really the prevention from toothpaste comes from the fluoride. There is a little yes, I will. There's a question just about information about the scheme, and I'll be putting some more slides up later on, and I'll send you to where you can find out a little bit more about the program. So I wanted to start with this statistic that being specialist pediatric dentists, and we work at tertiary specialist hospitals where we provide care for kids with disability all the time. But we couldn't actually do dental examinations on all the kids. And I think this is something that, it's sometimes hard. Partly it wasn't a clinical setting, so there's only a certain amount that we can do to do the checkup. But sometimes it is really hard to check the teeth of some children. That's the reality of this. The visits can still be really beneficial from a preventive perspective, but sometimes it is hard to do a good visual inspection of the teeth. I certainly found it was great fun being in the homes. They'd take you to the bathroom and then show you their toys and everything. I'm sure this is all stuff that you do all the time, Jo. But for me as a dentist that works in a dental clinic, it was like, oh, I can actually see where they brush their teeth. But I also learned that having a dental chair, kids jumping in there, it was a really good way of me being able to see. Sometimes it was harder to, we were checking teeth on beds and floors and couches and all sorts of places. But it was really good fun as well. And I think the families really valued it. Tooth decay was actually surprisingly common. So remember, they were talking about kids as young as 1.5, 1.5 years of age, so most of the kids were very young, but we were seeing, compared to the sort of general population, quite high levels of tooth decay. We're sort of there was like frank cavities in a couple of the kids, and there were even some abscesses, and a number of the kids had very weak teeth that sort of also needed follow-up as well. Okay, sorry about that. Okay, I might go into this. We'll get to the case next, I think. So as I mentioned, we also did some interviews with parents, and this about 11 parents joined over 10 interviews, and we were really trying to explore their experiences, what worked, what didn't work when it came to dental care, everything from toothbrushing through to sort of accessing dental care and going for the dental visit. And it was clear the families told us that they needed more resources and support, so resources just in general, even just information. Particularly, there's a lot of international, there's a lot of American websites and things, but they wanted Australian information actually. There was a lot of comment about that they would appreciate support from the health professionals that they currently engage with, and they trust and they know, and there were the OT, for example, that because they ask all their questions, they were going to asking about dental services, but the OT might not be as familiar with dental services. So that message really came through. We're certainly aware, and this is of course a challenging one for us to address, is the many barriers, long waiting lists, disconnected health systems, being sent from one service to the other. And for some families, there was the cost issue. For some others, the cost wasn't an issue because they were already well connected into the public system. Then there was a very strong message about the challenging environment of the dental clinic itself. It was difficult for parents to see, their child struggling, and also to see sometimes the dentist struggling, and knowing how they can support their child. Sometimes for some families, they were sort of dealing with new kind of recent diagnoses, and they themselves were sort of working things out, and it was really hard to then go to the dental environment. There's obviously a lot of strange noises, exposures at the dental clinic, and that was certainly a challenge. Not to, even toothpaste and the taste of toothpaste, like all of those things that I'm sure, I imagine many of you would be familiar with. I think we're going to...
Yeah, so we'll talk about Harry now, because I think it connects in with those findings and what we, I think, as clinicians often experience. So Harry's 4 with a global developmental delay, has got a history of family violence, was living with an aunt. And again, I guess that kind of picture of lots of barriers, but particularly with Harry's actual presentation himself. So with several attempted reunification experiences, Harry was definitely demonstrating a whole lot of separation anxiety, fear of strangers, avoidance of strange environments, and some of those challenging behaviours when his emotions were escalated, hitting out, and just real challenges following routines. Harry was pretty demand avoidant, which was likely around a lot of that anxiety stuff coming through. Our team were doing a lot of work around strategies to avoid directive instructions, to provide choice, and to look at visual supports. And I guess what we kind of really understood from the aunt was just how difficult all of that was navigating in her own environments, let alone considering taking him to a foreign space like a dental environment, dental chair. On top of that, there were the financial pressures, and I think a lot of us know how many different systems some of these families are navigating. So they'd been through, working with child protection, with Centrelink, with family violence agencies, reunification agencies. So they're navigating so many systems, like let's not even mention NDIS. So another system to navigate just was a really big part of this carer's overwhelm. And so for Harry also, we were able to kind of connect him to an oral health support through this project, through this research. He'd been coming regularly to one of our sites in Box Hill, felt very comfortable there, and so that's where he was happy to come with his aunt, and again with a key worker present who had the relationship, who had some of those skills, and working with the family around how to approach an assessment and how to get somebody to put their hands inside his mouth, with which was going to be particularly unfamiliar for him. So again, this was, I guess I can talk to this. This was actually a really positive outcome for Harry. Yeah. What did you find when you looked?
I mean, so the good news is, that we didn't actually, unlike the last case where we talked about lots of decay, there wasn't any actual dental problems. And so it's really important. That's what we want to be doing. We want to be having more preventive checkups when the teeth are healthy, supporting the family. And it was a really positive visit. He did really well. And I think the family were really relieved to have had that positive visit. I think, just being in that environment, having the toys, and it really made a big difference. And so hopefully, this is what we would like to see for all children, that they have positive preventive visits right from the beginning. I mean, the recommendation is that the first dental visit is at 12 months of age, or when the first tooth comes through. And not wait until there are problems and there's a need to, have teeth treated and removed and so on. So I think, and hopefully with that, we sort of establish that first visit. I think one of the challenges, of course, is that ongoing care, which we acknowledge that, for some families and some children, this kind of support and the opportunity to have a visit like this makes all the difference. But it does take a lot of coordination and a lot of effort. But it does make the difference. So I think that's the thing, that it is time consuming, and resources are necessary to provide that level of support, but it is what we kind of need to do if we're going to avoid having kids then go on to develop problems and ultimately just end up having their teeth removed. The data certainly seems to suggest, my summary of things is that whilst say autistic kids might not necessarily have higher levels of, say, tooth decay, they do tend to miss out on earlier treatment, preventive treatment, or simple treatment. So they tend to have more extractions and more emergency treatment, more sort of, and that sort of obviously affects children and their development, because they're not benefiting from, I guess, where dentistry can be most effective, which is in prevention and setting them up for health. Yeah. I wanted to sort of, I guess, so that sort of brings us to some of the quotes that we got from the families. So, this is, as you said, one of the parents was talking to us about that they're still learning the likes and dislikes of their child. And it is there's a lot of challenges in terms of getting into the dental clinic, where again, there's going to be difficulties. And we did have, we actually had, I should say, we had a lot of positive comments as well. Families that had made really good connections with their local dentist and felt that made all the difference. But then on the other hand, if they didn't have that, then it was much more challenging for the family. And then we, so I guess these two quotes kind of contrast a little bit, in that there's one where there's not as much experience with an autistic child, and then on the other hand, when they do have that experience, they're flexible, that environment is going to support that child. And then I think this is the last of the quotes, which really speaks to that. Again, families are wanting information, they're wanting resources, and they're wanting it not just from the dentist and the dental service. They really have told us again and again, and it's not just in this program, but when we've worked with kids across different settings and families, they want their GP, they want their maternal child health nurse, they want the health professionals that support them to help them with dental care as well, and that would make a massive difference to them. We, as part of that program, we actually we said we would develop a resource, and we worked very closely with families, and I just wanted to show you the examples of the resources that we ultimately came up with, because what families really wanted was very specific information that was meaningful to them and that was correct for them on one page, which was really hard for us to make because these we developed, obviously, are developed for Victoria, and as there is so much complexity in the different places where you can access care. We're doing a webinar that's not just Victoria based, and so I think it is hard in terms of giving that level of information that families need. And so we need to kind of be always ready for changes, new things come in. There are initiatives that look like options, but then in reality, they don't quite work out that way. And so there's a lot of complexity in navigating these services. I did want to just spend some time. I know we talked before about the Medicare Child Dental Benefits Scheme. It's the utilization is, as I said, only about 40%. I reckon amongst kids with disability, developmental concerns, autistic kids, I reckon that utilization will probably be even lower. So not everybody is eligible. There are some eligibility criteria, but it's much broader than, say, a healthcare card, which is what's usually used for public dental services. As long as they're sort of receiving any benefit of the child or the parent, they get about $1,000 worth of treatment. And most private dentists, 95% of the services are bulk billed. So, usually they're not having to pay any additional care costs, even if they're accessing that care privately. I encourage families to talk to the dental clinic and ask them. The dental clinics are usually quite proactive. The reception staff are quite good at contacting and reaching out to Medicare to check if families are eligible and how much how much is remaining on schemes and so on. There is some information here. So it's literally, you could Google it. This is from the Services Australia website. But if you literally type Child Dental Benefits Schedule, you will find the information from it. Families can access it through like MyGov, and it will tell them if they're eligible. It covers basic dental, so it does cover things like fillings and x-rays and even root canals, teeth out, and it is for kids from 0 to 17 years of age. It doesn't cover treatment in hospital, unfortunately. So for those kids with disability who do need more, who need a general anesthetic to have more complex dental treatment, then it unfortunately won't cover that.
Let's go to the question.
Yeah.
Because I know we're going on to another resource suggestion in a minute, but we have got a question around how do we get uncooperative children to open their mouths and stay open for an oral health check, and it was asked in relation to a home visit, but I guess in the chair as well.
Yeah. Well, I mean, we're pretty quick, quite honestly. We don't need a long time to check the teeth. I mean, kids will give you the time they can give you, quite honestly. I've always found that whether for home visits and even in the clinic, we do sort of a knee-to-knee kind of examination, so not necessarily in the dental chair for younger children. That tends to work quite well. I sometimes let some kids really like chewing on a toothbrush, so you might let them chew on a toothbrush on one side. That lets me have a good look at the teeth on the other side, and then kind of we switch sides and I can have a good look. Usually, if the parents are brushing at home, I might give the toothbrush to the parents and ask them to sort of give a go brushing the child's teeth, and I'll have a look. It really depends on the child. You sort of get a sense, many children will just open their mouth. Some kids don't want you near them, and that's like the full range. And sometimes it will be just like, I'm going to stand near this wall and let's just see how close we can slowly get. And many kids just need time. Like they need to warm up. And I think that's one of the things is that some, and certainly we've also talked to dentists and dental practitioners, and we know that sometimes they're under pressure for productivity. But having time makes a big difference for many. The knee-to-knee position is usually with the parents that are giving the child a bear cuddle, and then they just kind of gently tip the child back, and you have a little look, and that works quite well. That's generally the way that we will examine teeth. But like I said, occasionally it is possible that we don't get a good look in. We might try again at another time. There's lots of different things that we do. For children where I think it's going to be really difficult to check their teeth, I also think it's really important to spend time with the conversation before. So, sort of getting a really good idea about the things that we might want to check. And, the parent might say, oh, look, I'm worried about this little spot on the gum or this tooth up here. And, obviously that I'm going to take their cue first as well. So there are lots of, screens can work, distractions. I sing sometimes. I try to convince the parent to sing preferably, but if not, I'll do it. So like whatever makes the child feel comfortable. I think even some of the comments on the parents is having a more sort of play type approach to it really works. I think some kids really react as well when they sort of sense that clinic. Sometimes children even can sense that moment in the consultation where you've gone from just having a chat to suddenly putting your gloves on and they think, what's going on here? And they can be really little and they sense that, you can see the body language change. And I think a lot of it is that building that rapport with child and parents. So I don't know. That's a quick. I could talk about it forever, really.
I think it's a great question. I didn't know whether Chris wanted to share an example, or if you, Chris, had any thoughts on it. Thanks for asking the question. There is another question about CDBS versus Smile Squad. You want to come to that or go to the resource first?
Just what I think. Yeah. Look, the Child Dental Benefits Schedule is a federal government program. So it is available all around Australia. And it can be used in private and public settings. So some dental practices may not use it, but most do. And like I said, most are bulk billed. It covers basic dental care. Some things are not covered. But when you go to the dentist, you say, okay, I'm going to use, the child dental benefit schedule. And then they go, okay, sure. And then they sort it out. So it's usually something that you need to let them know when families attend the dental practice, so that because there's some requirements for the dental clinic as well in terms of using that schedule. Smile Squad is different because Smile Squad is a Victorian thing, which is run by the Victorian government, which is basically a school dental program. Up until this year, it was, I'm pretty sure it was only to government schools. And then this year they have extended it to low-cost non-government schools as well. It's done through partnership with community services, community clinics. And so there are, buses that go out to schools that will examine children. So usually the parents are not there, but will have provided consent. The Smile Squad will provide dental treatment there. If necessary, they also have capacity to refer for specialist care through the public system as well. But that is done on site through schools only, whereas the other one is offered through dental clinics. Eligibility is obviously different as well.
Well done.
Hopefully that's clear.
That is.
Do we have
nothing else at the moment?
Okay. So I do, there's probably a few things we could talk about. Toothpaste, we talked about toothpaste can be challenging. There's plenty of toothpaste out there that are not minty, not spicy, that some kids actually don't like the foaminess, the frothiness of toothpaste. It's a really common one. And I've found with, it's quite common that I'll have kids in the chair and the parent will say, oh, he's just not brushing his teeth. And I'll say, what is it exactly that you don't like? And sometimes it's like, can't be bothered. It's not really the most fun thing I could be doing. But sometimes they're like, I don't like I say, is it the foaminess? Is it the taste? And sometimes they might not mind the taste and they might say the frothiness. It's really common. There are some like non-foaming toothpastes out there that I recommend that can work really well. We do recommend brushing twice daily with fluoridated toothpaste according to the Australian guidelines, it's from 18 months of age. We have there are things that we can do. Some kids really enjoy using electric toothbrushes, some don't. Some like to mix and match. And there are a lot of products coming out there. I have to say, I certainly see a lot of parents who order stuff online, and I don't necessarily know if they've been fully evaluated. And I sometimes worry that parents are spending lots of money on things that maybe that's a common story across the sector. That not necessarily sure if it's useful, but yeah, there are newer things coming out as well. But we try to, if possible, doing the basics, which is twice daily brushing, some regular dental checks, and trying to limit the sugar as well. Yeah. You're keeping an eye on the questions.
So let's just go to the resource.
Yeah, oh, sorry. Yep, that's right. So just a few websites that might be helpful. So the Australian Dental Association has a website called teeth.org, which could be quite useful. I've tried to go with kind of Australia-wide programs here rather than directing you to sort of state-based things. Your local state might also have great programs. I know here OHV, for example, have some great resources as well. So the Raising Children's Network, Health Direct, these might all be quite useful in terms of resources. But we're also here if you want to contact us. Also happy to chat if there's things that are difficult, and if you need information. I think that sort of brings us towards the end. We do have, I know, Denise, I'm going to go back to you, but we would love to hear the experiences of early childhood sort of intervention practitioners. If about your experiences, there is if you use that QR code, it does take you about 20 minutes. So I'd grab a cup of tea, and when you do it, it's not a 2-minute survey, but it would be very helpful if you're able to complete it, to let us know about your experiences and what you find helpful and not helpful. Because we are trying to continue to sort of work in this space and, really address some of the insights we got from all these interviews and work that we've done in terms of developing resources. And so it's been great to work with Tracy, and hopefully we'll continue to do that as well. That's everything from us.
Thank you very much. Let me just pin you or spotlight you for everybody so that you're on there rather than everybody. Hopefully that's okay. Thank you very much for that. I learned, quite a few things. One was I love the flexibility of doing the home visits. I don't know how often that is done, but I know certainly for children that I've worked with in the past, who had a lot of challenges going to a dental clinic, having that as an option. And so that might be a question. Do you know how often that is offered around Australia outside of this research project that you did?
Not regularly. We're actually not aware of. I mean, there's a domiciliary service often across in states. It's generally done for aged care. Actually, it's not really done for child. There are some sort of a lot of it tends to be through schools, I have to say. Not really very many. I mean, the problem is, I guess it's always going to be a screening visit, but I think there's real value, particularly in early childhood, of these preventive screening visits. There are probably some groups who do some stuff. I know there's a team out in Sydney, I think, who, there's a few different teams that sort of, and there are certainly some private dentists that go out to places. So they might go to kindergartens. There's a lot of dentists that go out to kindergartens and things like that. But I think the other thing is we were also very comfortable doing this because we're specialists, pediatric dentists. So we do usually provide care for kids with disability. And so that might come into it as well, that it's sort of, there's maybe not a standard skill set for
Yeah.
some dental services. But it's certainly something that, I think would make a big difference to some families.
Yeah.
Can
No,
I,
definitely.
sorry, I was just going to ask a question, Joe and Mihiri. Just on that, I'm aware of quite a few oral health therapists who do go out into the home environment and are particularly early childhood focused. I'm just interested in your perspective on, that differing skill set, and also whether if families access an oral health therapist, are they eligible for the scheme? Can you use it with an oral health therapist?
Yeah. So anyone with a provider number can use it. So, and I think it speaks to the real value. And you'd have heard me sort of say dental practitioners, so oral health therapists, dental therapists, can certainly provide a lot of this care. I mean, it's one of those things that I think getting those services at home are really beneficial. I have to say, for us, we did it as a research project, so we didn't really have to worry too much about the costs and charging and so on. So I think those would be some of the things that need to be navigated through that sort of system. And as I mentioned with the Child Dental Benefit Scheme, there are some requirements of the dental practices that take part. So they would have to kind of follow those processes through Medicare and so on. But yeah, I mean, there's definitely, it's great to have dental practitioners going out there and doing some home visits. Yeah. But nothing that I know of as a standard kind of system, like a systems kind of approach.
No.
I don't think so. Yeah.
There was also another question on the chat just asking if there are any strategies that are non-toothbrush related. So, for example, things like, getting them to drink more water or diet things.
Yeah, so I mean, I guess it comes from tooth decay is probably the biggest problem we see when it comes to child dental health. And the common things that cause tooth decay are sugar and the bugs around the mouth, and so that's where toothbrushing comes in. Nothing really replaces toothbrushing, unfortunately. It is absolutely essential, but I know that sometimes it is challenging, and it's just the reality of things. I would also separate out toothbrushing, toothpaste. So there are some gels and fluoride varnish that can be applied, tooth mousse that may potentially be of benefit as well. You can sometimes use depending on the age of the child, you can use a higher fluoride toothpaste. Certainly water is great. Limiting sugar is great. They don't quite address the lack of toothbrushing though, and a lack of toothbrushing does also cause gum disease and inflammation of the gums, and that can be a issue particularly as kids get older. And I think sometimes, I do have some parents who say, oh, we don't always brush, but we, rinse with Listerine or something like that. Sorry, I just mentioned a product, but it's not like it that it's not quite the same, unfortunately. So sometimes I just say, look, do what you can. Take do a little bit and try again next time. And sometimes you get a good brush, sometimes you don't. That's okay. It's it's what you
assist.
Yeah.
There's another question which I've had this come up in my practice as well. For young children who can't spit, are there recommended products?
So I'm not too worried about, so I presume they're saying who can't spit toothpaste out.
Yes, and parents get worried about them, sucking the toothpaste and swallowing that.
Yeah, look, so tips are using low-strength fluoridated toothpaste. I'm not really worried, to be honest, if they're not spitting out. It's recommended in kids from, 18 months of age, and we're not really expecting them to be spitting out at that age. However, I do think going to a stronger toothpaste is definitely important as per our guidelines at 6 years of age, but possibly even before for many kids who are at higher risk of decay. In those cases, I suggest using a small amount, pushing it into the bristles rather than leaving it as a blob on the top of the toothpaste. That can help. And then just using a cloth or, something like a little face towel sort of thing to wipe off any excess. To be honest, if you're using just a small pea-sized amount, it's still a very, very small exposure anyway. So I'm not too worried. And I would still go with a fluoridated toothpaste. The evidence is just overwhelmingly clear about fluoridated toothpaste. But like I said, there are products like tooth mousse, which is a milk-based, calcium phosphate-based kind of product that can be used as well. But I kind of use them as second to the toothpaste, and then it's adding something else that families have to do, and they've got enough to do. So that's kind of the challenge. We can put fluoride varnish on though, but a professional can do that as well.
I've heard that sipper cups can have an impact on oral hygiene, not necessarily in a good way, but have never found a reference.
Yeah, we sort of have some recommendations sometimes. I enjoy digging into some of the recommendations that we ask parents to do. We do recommend transitioning to a cup as early as possible, so from 1. And the reason is, I think, it's actually linked to a very distinct pattern of tooth decay, which we get when children fall asleep with a bottle of milk in their mouth overnight. The mouth dries up, the saliva is no longer able to protect the teeth, and you get quite a rampant pattern of decay if they're sort of sipping on a bottle through the night. So we recommend transitioning to a cup. To be honest, I don't personally have a problem with a sipper cup. And certainly not in terms of oral hygiene. I mean, I think, a sipper cup they're using and putting down and drinking and putting down is, it's not being used that frequently that it can have that much of an effect. So I think a sipper cup I see very much as a transition to a cup itself. It's the teat on a bottle that sits overnight, particularly that it's sort of pooling around the teeth that we worry about. Flossing. There's a question about flossing.
Yes, yeah, and I think Kerry just added to her question about the sipper cup. She thought it was related to the protective value of the saliva.
Yeah, so I think it depends on how it's being used. I just think sipper cups are less, like I said, less likely to be used like all the time. Kids are still, I guess it's more the bottles that are sort of sitting in the mouth, and it's particularly overnight when there is less saliva. Obviously, it depends on what's in the cup. So when you talked about that, and there's a lot of juice and things in the cups that we would like to avoid and just sort of stick to water. But yeah, so I think a sipper cup's probably towards that, sort of moving towards drinking from a cup. That's okay. But there's so many different designs as well, and how kids use them. I think it's also how they're using them. Yeah, so just there is a question on flossing. So I think toothbrushing is just really important. So I think if you can brush twice a day, you're winning. The research seems to tell us that when teeth are really tight together, you can get more decay between teeth. And so flossing can be helpful. I, as a pediatric dentist that talks to kids all the time, I mostly focus on brushing because I think most people are sort of getting that under control. And then if they've got really tight contacts, I might talk about flossing. The thing I do find helpful with flossing, and this is partly as, from when my kids were tiny as well, sometimes it just mixes things up. It's like, oh, we've put the toothbrush away, we've finished. Now let's get out our little flossette thing, and you might do a couple of flossing. But really, it's only for teeth that are very close together, really black back teeth. If families are interested and able to do it, that's great. I would be great to do. There's surfaces of the teeth that need to be cleaned. But I sort of really think brushing is the first thing. And we know from the stats that teeth aren't being brushed twice a day with fluoridated toothpaste. So I say focus on that first. And often kids have gaps between their teeth, so you don't need to floss if there's gaps. It's usually by 6 the teeth start to get a little bit close together because the back molars come through. So yeah.
Okay, well, look, thank you very much, Mihiri and Joe, because we've hit 1 o'clock here in Perth, but whatever time it is around the rest of Australia. So thank you very much for presenting and answering those questions. I think it was really valuable, such a great topic to be able to have the time to dive into. I think you've given some great resources. I was going to ask, are the social stories available as templates or at all where people can access it? Or
we are working on it. We just haven't quite got there yet.
Okay.
Like I said, that was our first version. We also think we want to do a slightly better version. But watch this space, and I'll come back to you, because I think that's something that we I mean, with social stories, they really should be personalized, right?
They do need to be.
Yeah.
But sometimes a template is a great place to start. Especially if you need good pictures of whatever, is specific to the dental sort of area. So, look, thank you again. And thank you to everybody who attended and who provided some of the questions. It was, again, great to be able to unpack those. So, I hope everybody has a wonderful weekend. And thanks again, Joe and Mihiri.
Thank you
for having us.
Thank you. Bye.
Bye.